Thank you for joining iMeet. This meeting is now being recorded.
I'd like to welcome everyone to this AABIP webinar series. Dr. Christian, can you go ahead and introduce our session?
Yeah, thanks, Dave. Hello, everyone. Once again, thank you for joining us for another highly anticipated edition of our AABIP webinar series. I'm Ara Christian, coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw, we're excited to have everyone here. Before the formal introduction of today's topic and speaker, I'd like to review a few housekeeping matters. So first, everyone, please note that this webinar will be recorded. It, along with previous webinars, can be viewed on the AABIP website and can be found under the Education and Training tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and help optimize the overall listening experience, both for the webinar and for future listening. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. To ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking the thought bubble icon located in the bottom left of the iMeet window. Now, we leave it up to the presenter to answer the questions as they appear during the talk. But we do keep track of the questions as they come up, and since we will have a formal question and answer period at the end of the discussion, please feel free to type in your questions at any time. Also in the bottom left of the iMeet window is a projector icon. This allows the audience to toggle between the presenter slides and any videos. And finally, a couple important disclaimers before we begin. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things back over to Dr. Shaw for our formal introductions today.
Thank you, Ara. Today we have a topic on how to build an academic career in interventional pulmonology. We are very pleased to have Dr. Dan Sterman from the NYU School of Medicine join us. He is uniquely positioned, as many of you may know, to discuss this topic for us. He has a long track record of success as a physician scientist, and he also is in the role of leadership within a large academic center at NYU, where he is the Director of Pulmonary and Critical Care and Sleep Medicine at the NYU Langone Medical Center. Dan, thank you very much for joining us.
Thank you so much for having me. Are you ready for me to get started?
Let's go ahead and get started. Yes, thank you very much.
Sure. Well, good evening, everyone, and thank you very much for taking time out of your busy evenings or afternoon, depending on where you are in the country. And I appreciate the opportunity that Ara and David have given me to give a webinar on something that I live every day, both for myself as well as for my mentees, both here at NYU and those people that I've helped train who are around the country, which is how to build an academic career in interventional pulmonology. And I was lucky enough to be one of the maybe second phases of pioneers in developing this field many years ago, starting when I was a fellow. And I know that you on the call tonight, on the webinar, and the organizers are the future of this field and will be taken to the next level. And I hope that more than anything, the opinions that I'm going to give you today, and really their opinions and my experiences, will, I hope, provide some guidance as you build your own careers. The other thing that I'll say is that we have a mixed audience today. We have pulmonary fellows, we have potentially IP fellows, people who've matched in IP fellowships, we may have IP faculty, people maybe even senior or mid-career faculty. So I'm going to try to give a broad exposure and experience that may be applicable to some or to all. And happy to take any questions that you might have along the way. I'm not going to fill the whole time with my slides, and I don't have any videos, so happy to answer any questions that you have. And I'm also happy to be interrupted during the course of my discussion. So let me start with what is my significant bias, and that is that the field of interventional pulmonology, as we understand it today, the field from a comprehensive perspective, best functions, in my opinion, with an academic medical center. And I think this is relevant, as I think I'll show you, to how one builds an academic career in interventional pulmonology, because I think for several reasons, which I'll state, I think it's challenging to try to create an academic career outside of the realm of an academic medical center as an interventional pulmonologist. So why is interventional pulmonology, in my opinion, optimal in an academic medical center? I think to be a fully functional interventional pulmonary program offering the full panoply of procedures in our field from an airway and a pleural disease perspective, and to have the volumes required for training as a fellow and even to continue to acquire experience to develop expertise as a junior faculty member, it requires the referral base, in my opinion, of being in a regional tertiary quaternary care hospital, often which is the focus of a large healthcare system in which, in a hub and spoke model, patients with problems that require an interventional pulmonologist are referred into the system, as opposed to being out at the far end of one of the spokes where you may be a very well-trained interventional pulmonologist, but you're seeing a small subset of the patients and the problems relevant to interventional pulmonary, which is sent into the central hospital. And specifically, I think that there are high-end interventional pulmonary procedures. I just mentioned here rigid bronchoscopy for central airway obstruction, that it's very challenging to get the kind of numbers to develop and maintain competency and excellence outside of a regional referral academic medical center. And I think that often we depend upon referrals from well-established thoracic oncology programs. A big part of what we do is thoracic oncology with active clinical trials, and these are far more prevalent in academic medical centers than they are in the community, although they can exist in the community. And I also think that there are other technology-intensive programs that IP thrives in and that feed on the growth of not only the clinical aspects of interventional pulmonary, but the research component of interventional pulmonary, and these include things like lung transplantation. So there are relatively few lung transplants that exist truly outside of an academic medical center, and I think that this is just one example of how the coexistence of high technology programs helps IP grow and helps IP grow both as a clinical and a research institution. And so if you want to have a successful academic career, and I would say that you could have a very successful clinical career, but an academic career in IP is really facilitated, in my opinion, by the collaborations, the mentorship opportunities, and the clinical opportunities that an academic medical center offers to the interventional pulmonologist. We move on to the next slide. So just stepping back for a minute, and when I created this talk a year ago, and I've modified it since, I went to look to see is there data to anything that I'm saying? So is there any relevance to being in an academically oriented program to later academic success? And so I found this paper that came from groups from Virginia Commonwealth University and Medical University of South Carolina, which looked at fellowship programs, pulmonary and critical care medicine fellowship programs, and their academic and research components, and whether there was a correlation to whether fellows stayed in academic medical centers. And I realize this isn't exactly the topic we're talking about, but the bottom line, what this paper showed, published in the Annals of the American Thoracic Society 2 years ago, or 2.5 years ago now, is that there seems to be a significant correlation between the amount of academic requirement by the pulmonary fellowship and the subsequent retention of fellows from those programs in academic medical centers for their careers. And that this was a specifically statistically significant association when the scholarship requirement was for individuals to do peer-reviewed original research, different from, say, publishing case series or case reports or just doing a review article. If you're doing peer-reviewed original research and submitting this during your pulmonary fellowship, you're likely to stay in an academic medical center. And I would say that although this is a leap of faith, the same is likely true for interventional pulmonary training as well. And I'll try to show you some additional data over the course of the next few minutes that suggest that this may be the case. Let's look at the next slide. And the next slide is also a paper from 2.5 years ago, and it needs to be updated in the next 2 years. So if anyone wants to find an interesting clinical and health services research area looking at interventional pulmonary from from jaundice perspective, I think can be very valuable. And so this paper from the Johns Hopkins combined with Ohio and the Beth Israel Deaconess in Boston looked at employment data for IP fellowship graduates. This doesn't tell us what happened during the IP fellowship, but it tells us that the majority of people who are graduating, at least for the first 3 years post the IP match, went into academic medical centers, academic programs. And the minority, although not an insignificant number, ended up in private practice programs with IP. And some of these were hybrid programs where they're doing IP and other pulmonary disciplines, including general pulmonary medicine and critical care. And I'd also point out the number that were creating an IP practice. And so one of the things that we'll talk about in terms of how you have an ideal academic interventional pulmonary career is how you're starting off. And I think it's a huge undertaking as an IP fellow to go to a private practice or an academic medical center and to be the first person in to develop an interventional pulmonary program, just from a clinical perspective and an administrative perspective, and dealing with all the hurdles that has to take place for that to be successful. But to do that and then to build an academic career on top of that is very, very challenging. And so what I would say is that joining an interventional pulmonary group, and then we'll talk about this more in a few minutes, for someone who's academically minded may be an easier path. For those who are really interested in the academic and research components of IP, although you may not be the person who leads the program, you may help the program build its research component. And then the same article looked at where the interventional pulmonary fellowship graduates went, and this is old data, and again needs to be updated. But for the most part, these are fellows who are going to programs in the Northeast or the Midwest or Texas, California, and there's a huge swath of the country which is not being represented. And it is interesting that most of the places that have the highest numbers of graduates going have also the highest number of academic medical centers. And so my guess is that the programs in the states in blue that have acquired the most recent graduates, at least as of this paper from 2.5 years ago, are also the ones that have high-end academic medical centers in which interventional pulmonary is being performed at a very high level. So in every talk, there's one slide that if you zone out for the rest of the talk, that this is the one that you want to remember. So this is my overview for the next few minutes that we're going to talk about. And I'm just going to go over this fairly rapidly, and then we'll go over each specific bullet point afterwards in more detail. And please, if you have questions, let me know during the process. So in thinking about how I would design an ideal career as an academic interventional pulmonologist, sometimes you have to go back in a time machine. And I think that for those who've already finished pulmonary fellowship, the first bullet point is not going to help you, but I think perhaps the most important aspect of having an academic interventional pulmonary career is having a strong mentored research experience during your pulmonary fellowship. I think that will set you on the path to academic productivity, to academic success, and to a feedback loop of positive reinforcement of experience doing research. Secondly, I think that for those who have not yet applied for IP training or are just starting or poised to start next July their IP training, I think success in an academic interventional pulmonary program depends to some degree on who leads that program, and having experienced senior leadership, not just senior leadership from a clinical perspective, but who have been successful from an academic perspective, will have a significant impact on their trainees, their interventional pulmonary trainees, and their likelihood of going on to success as an academic interventional pulmonologist. I think that it's important, whether you're a fellow and especially as a junior faculty member, to find a clinical niche within interventional pulmonary, whether it be mesothelioma, tracheobronchomalacia, emphysema, photodynamic therapy. It doesn't mean you can't do other things. It just means that you should find an area or maybe two areas which can be the focus of what you want to build from a research perspective. It doesn't mean that this is all you do from a clinical perspective, but as I'll get to in a few minutes, I think it's hard to be an expert on everything and to be a researcher on everything. And I think it's much easier and better, you'll be better positioned to be recognized regionally, nationally, internationally if you find a clinical niche. And if you're having difficulty, to ask your mentors to help you find one. And this is a segue to the next bullet point, which is that you need to find during your fellowship, your pulmonary fellowship, your IP fellowship, or as a junior faculty member, a willing, competent, experienced, and ideally funded research mentor. And as I get to, this is ideal if your mentor is in your section of interventional pulmonology, but it doesn't have to be. And we'll talk more about who that mentor should be in a few minutes. I think that the bullet points points I'm about to talk about in a minute are going to be painful because they require work. But I think that they're the honest truth, which is to be an academic interventional pulmonologist, you have to write papers and you have to write grants. And that's how you're going to be successful. And it's hard because it means working at night. It means working in the mornings. It means working on weekends. It means sometimes working during your vacation time. And it's the dirty, honest truth of academic medicine that this is how things get done. As we'll talk about, you're not going to have a lot of free time during the course of the day as a pulmonologist to do these things. So you're going to have to, at least initially, find the time. In terms of writing papers, we can talk about the different type of papers to focus on, but in highlight, I want to focus on original research articles. This is how you're going to have your greatest success. In terms of grant writing, it's a very hard road to hoe. It's very important to at least try. You're going to have rejection, and I hope that you'll have success. And I think if you persevere, you will, and we'll also get to this more in a few minutes. I think that the second to last bullet point is important. It's important to go beyond your comfort zone, to establish collaborations, not only within your section, within your division and your department, but beyond that, and even potentially beyond a school of medicine into other areas within the university, in other departments, even outside schools of medicine. So collaborations are how we can best succeed, and we can leverage whatever free time we have or don't have to be more successful in our academic careers. And lastly, I'm going to teach you something that I learned the hard way, which is sometimes you have to ignore the debt that we all have incurred during the course of our training and try to pursue your passion despite the debts that we have. And it's easy for me to say at this point in my career, but early on I was pulled in different directions, including moonlighting to pay off student loans and my mortgage and tuition for my kids. And it's hard to do that and be successful academically and still get 4 hours of sleep a night. And I would encourage you to try to think about the debts that you've accumulated or will think about accumulating and how that jives with what you want to do with your career. And understand that it will have a direct impact upon what time you have, because you only have so much time as a human being, and you still have to make time for a real life. outside of your clinical and your academic pursuits. So think very carefully about the debts that you take on during the course of your life. Okay, so that's the overview. If you want to sign off now, you can sign off. I believe there might be a question. Nope, there's not a question yet. So we'll hold off on that. If you have questions, I'm glad to take them at any time. So let's talk first about mentored research experiences, and I'm going to lump together research experiences during both pulmonary fellowships and IP fellowships. And I would say that if you're a pulmonary fellow and you're thinking about IP as a career, and you're thinking specifically about an academic career in IP, I think you're best off finding a research project which is somehow related to IP. And I throw in here thoracic oncology, and that's my complete bias because that's the area within IP that I've focused on during the course of my career. But it could be research in COPD, advanced asthma. As IP branches out to all these areas, it could be pulmonary alveolar proteinosis. It could be something that you can then parlay into a clinical and research niche that you can focus on during your IP fellowship and your career. And it doesn't have to be the same thing, but I think that research projects should in some way correlate towards your career path. And I say that with a grain of salt because I also preach that any research experience is valuable, and even spending time in a basic science laboratory unrelated to IP could be valuable in being an academic interventional pulmonologist down the road. But I think ultimately it's an easier path to success, excuse me, if you have a project which is somewhat related to what you're heading into. The next idea, point number 2, is to try to find time during your IP fellowship to do research. And this is very hard. And this gets to a point we'll make in a later slide, which is that most IP fellowships maybe give lip service to having projected time for research. But if an IP fellowship is worth its salt, you're going to be working very hard as an IP fellow, and you're going to be seeing patients, doing consults, making phone calls, and mostly doing procedures, talking to families, talking about end of life, talking about risks and complications of your proposed procedures, and you're not going to have a lot of time for research. So talk to your program director, see if you can carve out an afternoon on a regular basis. But this is a significant challenge, and as someone who helped build an IP program and an IP fellowship and now runs a division which has an IP fellowship, I realize this is a significant shortcoming of the way we've designed them. Bullet point 3 suggests that if you're thinking about an academic career in IP, that you consider an IP fellowship that has a dedicated research year. To my knowledge, we only have one such fellowship currently, which I believe is the Johns Hopkins program. But I think that if our field is going to grow and grow in an academic perspective, we may need to think about adding additional research year for more than just one program, because this is how we're going to grow in the same way that pulmonary fellowships needed to have research dedicated for them to grow and to build academic careers within pulmonary medicine. I think that, as I mentioned before, during your pulmonary fellowship or your IP fellowship, you should be establishing a mentor, and your mentor should have research experience, and the mentor should have a track record of research funding. It's those individuals who have a track record of obtaining any kind of research funding, foundation funding, NIH funding, funding from ATS, CHEST, AABIP. They will be the best mentors to guide you in developing your career, because research funding will be how you carve out time so that you can do research going forward in the future. To note bullet point 5, that your mentor can be a non-interventional pulmonologist. It can be another pulmonologist in your division. It could be even a non-pulmonary critical care medicine physician. You could have an oncologist as a mentor, a pathologist as a mentor, a basic scientist as a mentor. Again, having someone who has significant research experience, who can help guide you in the area that you're moving to, who has a track record of research funding, is the most important thing. And someone who's willing to actually be a good mentor, to spend the time with you, to sit down with you on a regular basis, to go over data, to be critical of your writing and of your data, because constructive criticism is the way we learn, as hard as it is. So I think this, number 5, can be the most important thing during your training. And then lastly, as you do your research, show the world. submit your abstracts to ATS CHEST, World Congress of Bronchology, other international and national meetings. And I say research abstracts because many of us as fellows, pulmonary fellows, IP fellows, submit clinical abstracts. We performed the last 700 rigid bronchoscopies. That's not research. I'm talking about original research, which is hypothesis-driven, in which we can disprove these hypotheses during the course of the research. This is really important if you want an academic career. We want IP to take a path which is dissimilar from that of, say, surgical research from 20 or 30 years ago, where they just described the outcomes of their procedures and didn't look at them in a critical fashion. And so you can do clinical research. It doesn't have to be basic or translational, and it can be valid for submission, but it should be research nonetheless. It should be hypothesis-driven. And as a sequela to number 7 is that take every opportunity when you're invited to present your research to an academic audience, present to your division, present to your section. If you're invited to give a talk at ATS or CHEST, gobble up that opportunity. The same for World Congress of Bronchology. The best way to learn how to be an academic and to present your data is to present your poster, to present an oral presentation, and never turn up these opportunities, especially as a fellow or as a junior faculty member, because you'll learn from the presenting process and you'll learn from the criticism and the questions that you'll get during the presenting process. So how did I get to where I am now? Just for background, I was a liberal arts major in college. My major was in Russian history, Soviet foreign policy. I had minimal research experience going into medical school, minimal research experience in medical school, relatively little in residency. In fellowship, we had a mandatory 1 to 2 year period of time in a basic science laboratory. And I happened at that time to run into a mentor who was a brilliant biologist, lung biologist, who had no prior research in cancer, but was interested in building a cancer-related laboratory and was willing to put up with someone who didn't know a lot about science and to train me in the language of science and the techniques of science, even when I was quite upfront about not wanting to be a basic scientist going forward. And over a period of 4 years of fellowship and then 17 years as a faculty member, in that 21-year period, we built a symbiotic relationship in which my mentor would develop things in the laboratory, I would develop things that I could then bring to the patient, and then we developed this iterative cycle where we would go back to the patient to the laboratory and the patient to the laboratory. And the result of that, I hope, will be in the future advances of patient care, but certainly in the interim, it led to advances in translational research. And for me, it really was that identifying that mentor. And for me, it was a lot about serendipity, being in the right environment, and perseverance, and not giving up when my experiments failed, when my grants got rejected, when my papers weren't published. So again, if you're a fellow and an applicant and you're looking at interventional pulmonary training, and if you're a fellowship director in an IP program and you're going to have people looking at your program, I'm advising people who are pulmonary fellows looking at IP fellowships to look at the website, talk to people about the program, how successful people are in developing an academic career, to look up the faculty on PubMed and see how many papers they're publishing and what kind of papers they're publishing. That you should interview, if you're an applicant for an IP program, interview the faculty and the fellow during the process and ask them about their research experiences and their opportunities and their grant funding. Even go so far as you're going to think about where you want to rank in your match list, talking to graduates, recent graduates of IP fellowship programs regarding what kind of research and academic exposure they've had during the program. And you should certainly look, if you can, if there's data out there, or reach out to recent graduates to find out what kind of positions they were able to achieve. Where were they recruited to? And what kind of academic access and success have recent fellowship graduates have? Because if you want to be a successful academic interventional pulmonologist, as I mentioned, that track record is going to be exceedingly important. And if there's not a track record, It's going to be very hard for you to be successful. You can do it, but you have to do a lot on your own, and it's a hard process to do on your own, to be truthful. So just looking at academic productivity, there's only one paper out there, again from the Hopkins group from 2.5 years ago, which showed that when you looked at the academic productivity of IP programs, that the highest academic productivity came from those with the highest academic rank. And this seems to be self-evident, but I think it's also important that if you're applying to IP fellowships and the IP program is populated by assistant professors and instructors, they are just establishing their own careers, both from a clinical and academic perspective, and it may, not necessarily, but it may be challenging then for being successful mentors for you. And so look at the associate and the full professors and those faculty members who advanced degrees, master's degrees, and PhDs and other advanced degrees as those who be most likely to mentor you. So if you're looking to apply, if you're looking for joining a program when you're finishing IP fellowship and you want to see who your colleagues are going to be, this is the kind of thing that you should be looking at, because it will parlay, I believe, and this is my bias, into the greatest likelihood of success going forward. The next slide has to deal with establishing a clinical niche. And I just want to say that I think, in my opinion, it's hard to be a jack of all trades and distinguish yourself within any field of medicine. In IT, you can be an expert in rigid bronchoscopy and thoracoscopy and whole lung lavage, in navigational bronchoscopy and photodynamic therapy and percutaneous tracheostomy from a clinical perspective. And we need to maintain competency in all those areas. But to be an expert in looking into research in all these areas is very, very hard. And so I think that you should think about, as you're going through fellowship and as you're a junior faculty member, what is the area that most excites you, that you want to explore? What is an area that there hasn't been a lot of exploration in, that there needs to be attention and focus in? And so I would ask you to be very critical looking at the field, going on PubMed, seeing what's being published, seeing areas where you may be able to develop collaborations at your institution. There may be an oncologist who's interested in small cell carcinoma and know that this might be an area where there hasn't been a lot written on biomarkers, for example, and you could develop a collaboration in small cell. There may be a radiologist who's interested in imaging of tracheal stenosis, and you could develop a collaboration in that area. And I would also say that finding a specific disease entity is great, but it may be a more general area, which is you're going to focus not just on mesothelioma, but pleural disease will be your focus. And you may focus on tracheomalacia, but you may say benign airways disease is really what your focus wants to be. Or you may say lung nodules, but maybe lung cancer screening is a bigger pot that you want to investigate over the course of your career. I do think that it's hard to be in pleural disease and benign airways disease and lung cancer screening as an expert from a research perspective simultaneously. There are people who do it. I think it's hard to be in all those areas, and I would discourage those who are just starting the field from trying to build their research career from such a broad base. And I also say that there's not one way to do investigation into these clinical niches that you're identifying. You can do it from a basic and laboratory science perspective. You can do it from a pure clinical perspective. You can do it from a health services or health economics perspective, or you can do it from a translational perspective. And I put that in quotation marks because translational research means a lot of different things to different people, and it can include everything from doing human clinical trials to doing analysis of human specimens from the clinical trials to even developing biomarkers. But it does mean learning something about correlative science that you can apply to the clinical care of a patient. So as you're thinking about starting in an academic field, one of the first ways to do it is to write a grant. Writing a grant, especially with your mentor, with an experienced mentor, gives you an idea, even prior to writing your first research paper, to organize your thought. You have to put together your hypotheses, your aims, how you're going to try to answer those hypotheses as best as you possibly can and achieve your aims. And look at what your pitfalls are going to be as you're trying to get there and how you're going to overcome those pitfalls. So writing a grant can be an incredible exercise as you start off as a fellow or as a junior faculty member and trying to build that research niche in that area. And you can start with local organizations. There are local organizations that want to fund projects that you can go to. These are usually low-hanging fruit that fund 50% or more of the applications. They're not a lot of money, but they can get you some seed money. They can buy you kits to do a study or maybe an afternoon a week in which you can start to build some research time and buy some research time away from the clinical responsibilities that you have. You can then apply the next level to foundations in our field. The Chest Foundation has grants that are relevant to IP. One of them is Longevity Grant, which is focused on lung cancer. ATS has research grants. AABIP has a research grant for pilot studies, which is really important and should be something that IP fellows and junior faculty should be targeting. You should think about, even before submitting your own larger grant to, say, the NIH, to collaborate with others who are more experienced as being a co or sub-investigator on their grant. You can get a small amount of funding. You can learn to review their grant and learn how to apply constructive critical techniques to reviewing their grant and to offering suggestions. And then reading their grants will also give you an idea of what will be expected for your own grant application. Then the next steps are the steps that you go through to then develop a successful NIH-funded career. And if you want to work at a major academic medical center and be recognized as a successful academic physician, and a physician scientist, a clinician investigator, it is still to this day, although it's very hard, it is still the currency to have NIH funding of some sort, even if it's collaborative funding. And this can start with K-level funding as a junior faculty member, which would be a K01 or a K12. It can be a K23, which is a clinical research-oriented grant, a K08, which is a basic or translational science grant. And these are steps that then lead to larger grants, including the R-level grants, and then the larger grants, the program project grants and the U01 grants, which are collaborative and multi-center grants. And we'll talk about that as the next level a little bit on the next slide. But one of the challenges is that if you want to build a research career, as hard as it is to carve out research time in a busy clinical life, it's equally as hard to carve out clinical time to maintain competency if you're focusing on your research. So if you are successful in getting a K23 or K08 grant, the NIH limits the amount of clinical activity you can do to 25 to 30% of your time. So think about how you would maintain competency in procedures like rigid bronchoscopy and thoracoscopy if you're limited to being a 25% clinician, and the challenges of doing both things well. So I think that this is something that we'll talk about in a couple of minutes when we talk about the pitfalls and challenges in IP. I don't want to go into detail about the next slide, except to say that this is a paper published from about 10 years ago now, but I think it's equally as relevant today. This was meant towards all of pulmonary critical care medicine and really all medicine in general, but looked at NHLBI funding from a medical student all the way through senior career faculty grant funding. And just so you see that there is an organized process from F grants through T32s, through F32s, through K awards, to R awards, to a K24, which is a mid-career award for mentoring others to do patient-oriented research, and really the currency, which is R01 grants, get you promoted in an academic medical center, and then putting together R01 grants together as program project and larger grants, including U01s and SPORE grants. So what did I do in my own career? As a pulmonary fellow, I was lucky enough to have funding for research that funded 2 years for me to work in a laboratory on a T32 grant. I then applied for an RSA and American Lung Association grants, which did not get funded. I got funding from other foundation grants. I got funding from my mentor, which is important to have a mentor who has an R01. I then applied for a K award and had the challenge of both starting an IP program at a major academic medical center and having a K award. So how did I do this? With what I just told you about having only 25% of time, I fudged it. And how do I fudge it? My research was in a clinical area, clinical translational area that involved procedures. So it involved pleural disease. So in order to take care in order to do my research, I had to do research that involved thoracoscopy and other pleural procedures, including tunnel pleural catheters, and troubleshooting and learning about patients with pleural disease. And so this counted as part of my research, and then allowed me to sort of double dip and to have clinical time in which I could focus on airways disease and research time in which I could focus on pleural disease. This is one way to do it. It takes finesse, especially if someone from the NIH really wants to inquire about how you're biding your time. But it's doable, and it's one mechanism to be a successful researcher, to have some overlap between what you're doing clinically and what you're doing from a research perspective. Going further on, I was able to get an R01 equivalent grant 3 times through the PO1 mechanism. I applied twice with groups from multiple academic medical centers to have a SPORE grant, which is a multi-center, very large $10 million grant, which we applied for twice, spent countless hours applying for, and did not get funded. So just so you know, even successful people in academic medicine fail, and I failed multiple times during my career. And I've continued to try to pursue additional funding through foundations. And now, starting over again in a new institution, I've gone back through early phase R21 grants to try to generate more funds in new research areas so that I can submit R01 grants in the next year going forward. So about publishing papers, I want to spend not too much time except to say that you should be focusing on original research if you can. And if you're going to write about clinical cases, write a case series, which is better than a case report. Comprehensive reviews of a field are great, but if you can learn the technique, and it's a real science of learning the technique of a systematic review or a meta-analysis, that's far better than just a comprehensive review. But original research and original research which is published in high-impact journals is exceedingly important. And I would also stress that it's not how many papers you published, it's the quality of the paper and the journal and the number of times people reference your paper. That's the most important thing. So you can have published 500 papers, very low quality journals, and that's not the same as 50 high quality papers in high impact journals. So quality over quantity at all times. And you're going to hear this from your program director, and you're going to hear it from your chairman and your chief. They're going to ask for what journals are you publishing in. And so I try to focus on that with my faculty. And just to look at what I was able to accomplish in clinical translational research, you're not going to be able to you're not going to be able to publish hundreds and hundreds of papers. You may publish 3 or 4 key papers per year, and sometimes your research papers will only be 1 per year or 1 every other year in high impact journals. So it's a hard way to build an academic career. It's sometimes much easier in basic science because you can do 7 or 8 mouse experiments over the course of the year, which you can publish, and 1 clinical trial may take 4 years to complete. But you can make an impact and you can help patients going forward in the future. Think about establishing collaborations. We talked about this before. The collaborations can be related fields, in other fields related to your areas of research. You can think about collaborating with basic and translational scientists, epidemiologists, biostatisticians, and bioinformaticians. It's hard to do good high-quality research without having collaborations with biostatisticians today. And then think about, if you are interested in translation research, partnering with the laboratories that already exist at your institution, biorepositories, genomics core laboratories, flow cytometry core laboratories, so that you don't have to necessarily have all of the expertise yourself, but you can partner with people that have the expertise so that you can answer questions with others that have scientific merit in these areas. As I mentioned, it's important to pursue your passion. So as you're choosing faculty positions when you leave IP fellowships, you may be judging different salary levels. Don't judge it just on the basis of one program's offering me $250, one's offering $220. Think about the faculty position that offers you the chance to have the most success, that offers you the chance for protected time. Think highly about whether you want to start an IP program. It sounds really cool to be able to do that, but it might be better for your academic career to join 2 or 3 other experienced people so you can come in and be busy clinically, but have that opportunity for protection to build your academic career. And lastly, from my own negative experience, don't be overextended by moonlighting. Don't buy a house which is beyond what you can afford, and you have to spend your time trying to be house poor and paying it off. Think about what you want to do. If you want to build an academic career, you're going to need the time to do that and not time to focus on earning money. And there's an interesting paper that came out in the Blur Journal 11 years ago that interestingly showed that if you chose an academic career, that there really was no association between debt. So just having debt doesn't mean you can't be successful. It just means it may take you longer to pay it off. It's going to be harder, but you can be successful in doing this. So I want to leave you with the last couple of slides saying that there's no one way to do this, that there is no one path of research success to be a successful academic pulmonologist. And if you query the IP program directors and the fellowship directors and leaders of programs, I should say, you'll find each of them that's developed success in each one of these areas. Some people doing very basic mechanisms of disease, preclinical laboratory research, clinical translational research, medical device development is very common. I would caution that you have to be cautious about being a consultant versus being a principal investigator of clinical trials, because these create conflicts of interest. So think very carefully about which one you want to focus on. Do you want to consult and make money, or do you want to run clinical trials for industry? It's hard to do both without having significant conflicts. You can develop your own intellectual property and patents as you develop medical devices or other concepts, for example, biomarkers, and your own institutions can help you do this. You can do health services research. You can focus on the medical economics of our interventions and whether or not they're feasible and cost effective. And you can focus on medical education. And just remember this last slide just to remind you that medical education is a field in and of itself, that it's a science, that it can be studied like any translational or basic science. And so it's not just a matter of saying, well, I'm a medical educator because I teach fellows and house staff. Medical educators have components of their portfolio that your program director, that your division chief and your department chair will look at very carefully when they're considering promotion, and you have to hit all these benchmarks if you want to be successful. And so lastly, there are some questions that have come up regarding being successful in academic careers. And some of these we may have touched on already. One is, are there obstacles to academic advancement that are unique to IP? I would say within pulmonary and critical care medicine, the unique obstacle is the amount of time clinically and the incredible dedication, time commitment it takes to be a busy clinical academic interventional pulmonologist. We just don't have the time, and we don't have the mental energy, because so much of what we do is taking care of patients who are incredibly sick, often at the end of their lives, dealing with life or death situations. It's hard to break away from that and to write a paper or to write a grant or to do research. So I think that we do share that with our critical care physician colleagues. However, I will say that critical care doctors work shift work for the most part. They have more protected time for research if you're in an academic medical center than interventional pulmonologists, and so they may have a lower barrier to academic success. Common pitfalls, time sick and low yield activities. What I'm going to do when I'm done here, doing EPIC, charting on EMR, it's a bane of our existence. Documentation. I would say time sinks can include moonlighting, and it's a pitfall that we just talked about. So what factors go into myself as a division chief or the department chair someday looking at your productivity? Again, I would say it's the quality of your research work as measured by the type of academic productivity. Do you have grants? Do you have funding from the NIH? Are you publishing? Are you publishing in high-impact journals? Are your publications being cited? Are you changing medical practice? Have you had an impact upon your own section and your own division? Are you impacting upon the trainees who are then going on to success going forward? These are the things that I'm looking for in terms of developing a successful career and to be promoted from instructor to assistant professor to associate professor and full professor. And lastly, when you're attempting negotiations with your division or your department for time, equipment, and support, it's important to think about things beyond just generating revenue. It's very hard as a division director when I think about building my own interventional pulmonologist careers. I'm torn. I'm torn because I have to justify the salaries that you all deserve to earn and what I want you to be doing, which is to be asking questions, doing research, writing papers, and writing grants. And so I shy away from RVUs because RVUs don't reflect well in our field, don't reflect well on the time that we commit per procedure. Our procedures are among the least RVU generating procedures of any procedural field in medicine, and certainly don't compare to things in surgery. And we don't generate as much revenue, say, as our critical care colleagues in the other aspects of what we do. So you have to have an understanding division director and department chair who's willing to try to provide the resources and the collaborations for you so you can be successful, even knowing that you're going to be busy in your careers. And so I thank you for your time. I'm sorry for going a little bit over what I was supposed to talk about, but I'm glad to take any questions that people might have. And I hope that you can all be as happy and successful in your careers as I've been in mine, but also knowing that mine is ongoing. I hope to continue to try to be successful, to build collaborations, to continue to seek out mentorships for myself. And I'm still writing grants and papers even at my ripe old age. And so I hope you all know that this is an ongoing and exciting process that you're embarking on. And I thank you again for your attention.
Thanks, Dan. So at this point in time, we'll take questions from the audience, and Ara and I will be moderating those. Ara, why don't you go ahead and ask your first question?
Thanks, Dr. Sterman. That was excellent, exactly what we were looking for, and very thought-provoking. One of the questions that I personally have and also have been asked as well from many other faculty members, along with fellows that are considering a career in IP, is how to collaborate with other institutions as a means of jump-starting a career. So in particular, are there any existing structured interinstitutional research collaborations ongoing within the IP community? And if so, how would one join?
I think there are, and a lot of this is in process of development now. And so there is at least one consortium that I know of for IP-focused research, which encompasses about 5 or 6 of the major academic programs, whose goal is to be similar to what, for example, they have in oncology, which are these cooperative research groups that will conduct large-scale multi-center clinical trials to answer important questions. Actually, pulmonary medicine is far behind oncology and behind, say, rheumatology and cardiology in developing these, but IP is even further behind. So we're just getting started, and so there are ways as a faculty member, primarily as a junior faculty member, in reaching out to these key leaders of this cooperative group that's just developing, or even think about building your own cooperative group of institutions that can answer important questions together. And so first you have to think about the question. Second, you have to hear what was already being done. And third, learning about the cooperative group that's out there and what it would take to build your own or develop collaborations with them. So sometimes this is easier to do than trying to build your own research program at your own institution, especially if you don't have the infrastructure to get started. Why would it be easier? Because this consortium that's under development may have a clinical protocol that you can then translate into your own IRB's language and submit. Therefore, you can participate in a multi-center trial without having to go through the process of developing this all on your own.
Excellent. Thank you.
also make it one editorial comment. Is anyone still on the line?
Yes, we're here.
Okay. The other editorial comment I'll say is that the way we're going to be successful as a field is by developing randomized clinical trials. And ultimately, when possible, double-blinded randomized clinical trials. Many of our procedures are hard to blind, which is why many of the trials that have been published so far have involved sham control procedures. But I think that ultimately that's how we're going to grow. And as a field, interventional pulmonology is still young, and it's one that doesn't get necessarily the kind of respect it should get even within our own divisions of pulmonary and critical care medicine. And in part, that's because there's not a lot of science to it. And it's imperative and incumbent upon us to try to build that science going forward. And so if you're interested in answering major questions, think about how you can take something from the pilot stage, which is entirely appropriate to start off in, to larger scale phase 2 studies or feasibility studies, and then on to a definitive randomized trial, which can answer a question in a definitive fashion. So we've had a few of these. One of these recently was something as straightforward as the ASAP trial, which was published in the Blue Journal, which looked at standard draining techniques 3 times weekly versus every day for patients with tunnel pleural catheters. It doesn't have to be a highly scientific, genetic-focused question that you have to ask. It can be a very important question. How often should we drain a pleurix catheter or a tunnel pleural catheter? And those are important questions for changing the way we practice medicine. It could be something like the AIR2 trial, which looked at bronchial thermoplasty compared to control, and doing a randomized, blinded, sham-controlled trial to see whether intervention is better than the standard of care. We need to be doing these going forward in order for our field to be successful.
Great. So we have a question from, go ahead, Ara.
Oh, no, that's fine. Looks like Dr. Argento has a question here for Dr. Sterman. Dr. Sterman, how do you actually protect your time? How do you go about dealing with, again, a lot of local pressures within the division and the department? She writes that it seems to be more of a mystical number than a reality, especially when you're starting out and not so well funded.
Yeah, I would say that this is perhaps the biggest challenge, which is how do you get jump-started? It seems easy for me to say you need to find funding to protect your time so that you can then write a grant so that you can get more funding to protect more time. But how do you get that first amount of money? And I think that what I think about as a division director is how can I leverage resources that I have to help buy the time of a junior faculty member who's interested in research. So this is why I said thinking about finding a mentor in the section, in the division, or outside the division who's funded. Because often if they have grant funding, they may be willing to put you as a sub-investigator on one of their grants so that you can get, say, $25,000 towards your salary, which may buy you an afternoon. And that afternoon, so that you don't have to be doing procedures or seeing patients or working in the ICU, may allow you to write that first foundation grant or that first chest grant that you can submit and then get $100,000 for 2 years so you can buy yourself 1 day a week. And that 1 day a week may allow you to then go to the genomics core laboratory institution and learn about, say, RNA sequencing on EBA specimens and how to do it, and not necessarily how to be the one person in the lab to do it, but learn enough about the language so that you can send your specimens to the core lab and learn how to interpret it. And that will allow you then to get enough knowledge to submit a grant. So it's a stepwise process, but someone has to give you that leg up. You have to have that mentor, that division director, who sees something in you as a fellow or junior faculty member that's willing to make an investment. And it is an investment. And I see this all the time where I have to go on a limb. I've got a small amount of a slush fund that I have as a division director that I can use for a variety of things. Who am I going to use it for? Who has a good idea? Who do I think has the drive, the ambition, the dedication, the perseverance that if I give them a small amount of funds and protect an afternoon, that they're going to put that to good use. So I think that's it's the challenge, but the key is, as you're selecting a IP fellowship or a program to go to as a junior faculty member, these are the kind of questions you should be asking as you're selecting it. And if you're not finding it and you want to develop an academic career, you should think about switching jobs to a place that will allow you to do that.
Great. Thanks so much, Dan. And it looks like Christine also has a follow-up question, which is how would you take a how would you suggest getting funding to pay for a research assistant so you can actually get some help and have some time to pursue some of these research endeavors, especially as you're getting started? And then also, would you take a research assistant's help or protected time?
So the answer is yes. So I had a famous endocrinologist who would ask you questions about whether thyroid hormone would go up or down in the setting of some this disease or that. And the answer was always yes, because it could go either up or down. So I had a choice of a research assistant or protected time. I would rather have both. And so I think if I had to choose, I would choose the protected time. Because first you have to have the breathing space to come up with an idea and do reading. It sounds simple, but even just having the time to look over the literature and to read a paper and find out what's going on in the field. So I would take that afternoon, that half day a week first before a research assistant. And then what I would talk to my section chief, my division director, my IP director about is, can I share a piece of a research assistant with someone else? And the reality is, and you may have heard this in a webinar by Lonnie Yarmus previously, you can find people to help you out that don't cost any money. There are hundreds and thousands of people out there who are in college who want to go into medical school, who are taking a year or two off and doing a post-bac and want to be doing research. There are medical students who want to get into a good residency, and residents who want to get into a good fellowship, and fellows who want to get into that best IP fellowship, who may have time that they can give you to serve as a research assistant. They're not going to be full-time, but this is how you can leverage, when you have very few resources, bringing someone in to help you, and you're helping them in the process. So when I first came to my former institution and my current institution, this is how I helped build when I had a relatively small amount of funds that I could use, by bringing in others who were going to benefit in a mutually symbiotic way from us doing research together. So the combination of having a small amount of protected time to be able to have that breathing space, to think about your project, to then try to bring in as many free research assistants as you can, and then ultimately when you get that first pot of money, to then get a research assistant who's more full-time, to share a research assistant with who might be full-time, but you may not need them for the full-time. You can share them with someone else in another area of pulmonary who might be willing to go halvesies with you, and so you can bring someone in and fund them for the year. And then to think about whether there's someone on your mentor's grant who could also help you out. So I think that the answer is both, and the answer is both, and you have to be strategic in how you develop both simultaneously.
Dr. Sterman, it looks like Sanket Thakor, who looks like is a pulmonology fellow, was wanting a little clarification on the research consortium, interinstitutional consortium you were discussing.
I was trying not to focus on individual institutions in the course of our presentation, but I will say that Lonnie Yarmus at Johns Hopkins has started an interventional pulmonary research consortium. And if you're interested, reaching out to Lonnie, who's the key investigator starting this, would be a good start.
Excellent, thank you.
Are there any other questions? If not, unfortunately, I have to sign off. So I thank you, David, and to ARA for inviting me, and I hope everyone has a great evening.
Thank you, Dr. Sterman.